Okay, hi everybody. We're just going to talk tonight a little bit about skiing related knee injuries, snowboarding related knee injuries, and just a couple introductions. Rachel, who you've heard, she's organized this, so thank you very much, Rachel. And Josh Jones from Avalanche Physical Therapy is with us as well. And I'm basically going to give maybe a 10-12 minute talk, and then Josh is going to give a talk with some slides as well. I wanted to thank our research foundation, which funds these. And yeah, as far as a brief outlining goals, honestly, from my standpoint, it's a lot of pictures and not a ton of words. I thought just showing some cases will just stimulate some, hopefully, discussion and questions. I do want to tell people, though, that some of my slides, some of my videos are showing like a knee being examined or even like a surgical finding, and someone with maybe a queasy stomach or something. I'm sorry ahead of time if that is not well tolerated. I know some people like to watch that stuff, others not so much. So you might have to cover your eyes if you don't tolerate seeing that kind of stuff very well. So. Okay, so I thought we'd start with just ACL tears. And, the ACL, this is just a simple diagram, just looking at a knee. The ACL is that ligament right in the center of the knee, and behind it is your PCL. So this is the top of the knee and the bottom of the knee and the inside of the knee and the outside of the knee. And we talk about four main stabilizers to the knee. So there's the MCL, the inner ligament, the fibular collateral ligament, or LCL, on the outside, and then again ACL and PCL. And ACLs, definitely a very common injury. There was a study that looked at injuries in skiers and snowboarders, and this is all comers, all injuries, so even head injuries or shoulder injuries or wrist injuries, about a third were knee injuries. And of that third, about 50% involved tears to the ACL. So I would say in the skiing population, snowboarding population, of those injuries that involve the knee, about half involve ACL tears. So very common. And patients might feel that kind of dreaded pop in the knee, and tell Josh or myself, hey, yeah, I felt that pop, had pain, swelling, my knee felt unstable. And we've done some studies looking particularly at World Cup racers and how skiers tear their ACL. And this is just showing a slide. And so just to run you through this, this is called the slip catch mechanism of tearing one's ACL. And so the skier's obviously, somewhat out of control in frame A. And then in frame B, I'd be, of course, down the hill by now, but this guy is saved it. And he's about, though, to apply pressure to his downhill ski, but his knee is fully extended. It's fully straight, his knee. And then you can see, you could tell, maybe not from this angle, but he's in the back seat. So his center of gravity is in the back. And as soon as he plants that downhill ski, that's when you tear your ACL. So there's a sudden, like, we call it a valgus stress to the knee, but you can think of the knee as kind of caving inward. And, but it's usually contact, sudden force when the knee is in extension and one center of gravity is in posterior to the pressure on that ski. And that's how people tear their ACLs with skiers. There's other mechanisms as well, but this is really the most common, I would say. This is just another diagram. Like, in this diagram, this athlete on the left, when he comes down from, let's say, catching a ball, or in volleyball, basketball, something like that, we call it the accordion. He can basically flex at the hip. He can bend his hip. He can bend his knee. His foot is plantar flexed. It's pointed down. So when he lands, he can kind of distribute these forces completely up his axial skeleton. Whereas this athlete, when she lands, she can't, basically, there's not going to be no motion in her ankle joint to dissipate the forces. And she's not going to be able to, because her gravity or center of gravity is behind her, she's not going to be able to flex that knee to accordion and kind of absorb those ground reaction forces. And then her hip is already flexed, so she's not going to be able to bend her hip anymore. So all the force is going to go across one's knee. And this is how we see a lot of athletes tear their ACL, whether it be, playing basketball or landing in the back seat, coming off a mogul on your skis, this sort of mechanism. So instead of being over your skis and be able to accordion and absorb those forces and not tear one's ACL, that this kind of position predisposes to an ACL tear. This is in surgery, just looking at, we call this a Lockman exam. So you can see how the lower leg bone I can pull forward and how unstable that knee is. And that's evidence of an ACL tear. This patient's asleep in surgery, but I can do this exam in the office and appreciate the same sort of things. This is what's called a pivot shift test. And you can see how the knee kind of pivots out of place. And that again is evidence of an ACL tear. So those are the two tests that we would do in the office or in surgery to just, confirm that someone has torn their ACL. And then this is what an MRI might look like of an ACL tear. So again, we're looking at the knee from the side. Here's the thigh bone and here's the shin bone and the kneecap is here. And this is, for instance, their PCL, this dark ligament. And you can see that's how a ligament should look, but their ACL is actually, it should be right in this area. And we just don't see intact fibers. So in addition to a history that we're going to get in the office and a physical exam, we typically get an MRI scan. Oftentimes, to confirm that someone's torn their ACL, but usually in the office, I can tell 95% of the time if someone's torn their ACL, and an MRI is really indicated just to look for other things like meniscus tears or other cartilage lesions. For instance, this is an MRI of a normal ACL. You can see how we can really follow the ligament from the femur down to the tibia. So that's a normal looking ACL. And in surgery, we're preparing grafts. This is a quad tendon graft that we're going to use in surgery to substitute for one's ACL. And I have these pen marks on the graft, but that's a great graft if we're reconstructing an ACL. And so just going to jump quickly between topics here. Tibial spine fracture. So a tibial spine fracture, it's really honestly the same mechanism as tearing one's ACL. So here's a side view of a knee. And it's on a CT scan actually, and the ACL runs down where this yellow bar is, and it hooks on the bone here. But what this patient has done, instead of tearing their ACL, they actually have pulled up the bone attachment, the bone island onto which the ACL attaches. And this is what it looks like on a CT scan. So this chunk of bone kind of belongs down in here, and instead it's pulled upward. And I actually, yours truly, had the same injury when I was about 17 playing soccer. Needed surgery back then. It was done open. Now we do it all through the scope. And so this is, for instance, a scope picture of someone recently that I treated for a tibial spine fracture. So above was their ACL, which was fine, but basically this big bone island onto which the ACL attaches, I can just lift it right off, and it's not attached down here. It's fractured. It's pulled off. But if you had to choose, it's better to actually have this injury than a true ACL tear, because bones heal much faster than a ligament reconstruction. But there's their ACL, which actually looks fine. It's just that they pulled up that bone attachment. But it's the same mechanism as tearing one's ACL. Just the energy is dissipated across the bone instead of the mid-substance of the ligament. So, and this is what might look like afterward. This is one repair technique where it's basically all sewn back down into the bone. So it's done arthroscopically. There's no big incision. And again, these heal faster than if one were to have an ACL reconstruction surgery. And then something that I've been really excited about in the last maybe 5 years or so, in some cases, we can actually fix one's ACL, like repair it. And this is an MRI of someone that I think is a good candidate for that procedure. So here again, here's their ACL. And you can see they still have a semblance of an ACL. And unlike most patients who tear right in the middle, and as I tell people, it's kind of like a mop end. When you look in there, it's just two ends that are just not connected. This patient, really what they've done is they've pulled the ACL off of the bone attachment up here in the femur. And a surgeon I know in New York, and there's a surgeon in Germany, and there's I would say a group of people that are around the world starting to fix these. And I have a series of about 50 patients that I've fixed their ACL in the last 5-6 years. And the results have been great in the right type of tear. But I would say most patients, again, tear right in the middle of their ACL and they're not a candidate. But if you tear way up high, you might be a candidate for actually just taking that ACL and just reattaching it to the bone. And we use instruments very much like I would use in a shoulder on a rotator cuff tear, just to anchor that ligament back to the bone and let it heal. And that's where it's torn from. And then this is, for instance, a video of a 16-year-old girl that had a tear that I thought was amenable to. So you can see the ACL has been damaged, but basically it's torn way up high off the femur bone. And that's one that I thought would do very well with a repair, and she did great. And what we're doing is honestly kind of passing suture through the ligament. So we pass suture with these special suture passing devices through the ligament, and we weave the suture up through the ligament, and then literally we repair it back to bone anchors. And so this is the after picture, and so the sutures are seated in bone anchors in the femur, and then the ligament is reattached and allowed to heal. And again, I've been really pleased in the right patient to do these repairs and save their ACL. The rehab's much faster, and these are nice and stable. They feel great, and it's really minimally invasive. And I think I'm particularly excited in kids. Like this was a 10-year-old girl who tore ACL, and I did a primary repair on her, and her knee's nice and stable. And it's just such a better option in a young kid who's still growing and their growth plates are open. If we can take that ACL and reattach it, because the alternative is we're having to work around growth plates, and there's always a risk of injuring the growth plate, especially in a kid that's still growing. And so, so it's a great option. So MCL tears, MCL tears, the MCL is that inner ligament. And when I say inner, like if you tap your knees together, you're touching your MCLs together. And most patients tear the ligament off the bone on the femur side. That's where most people tear from. You can tear down here where it attaches to the tibia, but it's mainly up here on the femur side. And most of these heal fine. We'll just brace people in the office, but unfortunately, we have to see people soon. This is an injury that you don't want to blow off. You want to get in the office and get evaluated by myself, by Josh, have us feel that MCL, because if you're torn, we definitely want to get you in a brace. And it can be in high grade tears, we put you in these big hinge braces just to decrease the forces across the ACL. But it's the patients that don't get in a brace and maybe see me 3 months later and say, I hurt my knee 3-4 months ago or last year skiing. It's never been right. What's going on? And those are the MCLs that just, we've, kind of the horses out of the barn. We can't brace them anymore, because to brace them and get them to heal, we got to get on a brace on usually within the first week or so, and keep it on for the first 6 weeks, because at 8 weeks from bracing, it kind of is what it is. Like if we put a brace on 3 months later, it's not going to help. It's not going to help it heal. It's already elongated, and it's not going to shorten and heal any tighter. So here's a video of an MCL tear. And again, this is for those that maybe are don't want to watch this stuff. You may want to close your eyes for a moment. But this is in someone in surgery. You can see how loose that MCL is. Like, the whole knee opens up on the medial side. And I just had someone yesterday with an exam like this, and those are MCLs that need to be fixed, especially if they've failed a course of bracing and they haven't healed. In some MCLs, we'll look at right off the bat in the office and say, this isn't going to do well in a brace. We need to just take you to surgery and fix it. And this is one of those. So we're looking straight at an MRI of a knee, and here's the top of the knee and the bottom, the femur. The femur's up above, the tibia below. And you can see this is their MCL, and it's kind of this curled up structure, and it's like a rubber band that's retracted. And there's another portion of the tear here, but those particular tears do not do well in a brace. And that's one that we need to honestly take this ligament and stretch it back out and repair it, and then oftentimes augment it with a donor tendon over the top of it to reinforce it. So we can tell on some MRIs right off the bat if they're going to stand a chance to heal or not. Most do. But we grade these tears as we do any tear of any ligament on a 1 through 3 scale. And so 1s and 2s stand a very good chance of healing. But grade 3s, really the very unstable knees, those are the ones that typically don't fully heal in braces. But some people can do okay. If we can heal them from a 3 to a 1, they can do okay. But usually never normal. But this is, for instance, an MCL that's just, you can, like that MRI, it's right off the bone, and it just was recoiled up here, and it's just not going to heal. And so that's one that we want to reattach to the bone and guide it where to heal, to give it a fighting chance. Meniscus tears. Meniscus tears, this is scoping a knee, and this is kind of your degenerative type tear. So this is someone that just, someone my age, honestly, maybe in their 50s, they've played some sports their whole life, they have some wear and tear, and then they get these flap tears of their meniscus. And I tell people it's kind of like a pebble in your shoe that's getting caught in the knee, causing you pain. But you can see that tear, it's all white. It has no blood supply to it. So I could sew it back in place in surgery, but it's not going to heal. and it's not doing the patient any good. It's just catching in their knee. And so that's one that typically we're just doing a little meniscectomy on, partial meniscectomy, where we remove just the torn flap. But the goal is to save as much of the native meniscus as we can, because it's an important shock absorber. But even with a good repair of something like that, sewing it together, it's not going to heal. So that would be a little trim. But certainly as the surgeon, we want to save as much of the good meniscus, the working meniscus, as we can. And this is one that is a special type of tear. It's called a root tear, where they've torn it right off the bone attachment site. And that's definitely one we want to fix. This was in a young patient. I think they were a snowboarder, launched themselves off some massive jump, came down and really impacted the knee, and they ripped their meniscus right off the bone attachment site. And so we'll do something like this, where we pass suture through it, and then we sew it down into a bone socket so it can heal back down into the bone. So certainly I'm very aggressive about fixing meniscus tears whenever possible, but unfortunately, if they're not torn where there's blood supply, they're not going to heal. This, we get the blood supply from the bone, and so they'll heal. Bone bruises, you have a hard landing out there or a twisting fall. You see us in the office, and your exam's fine. Everything feels nice and stable, but you're painful. It's hard to bear weight even. So you can bruise your bone and cartilage, and this is what an MRI might look like of a bone bruise. You can see all this whiteness in the bone here on the MRI. The bone should be dark like so, and this is a deep bone bruise in the femur, and then all this is bone bruising down here in the tibia. And this patient happens to also have a bad meniscus tear, but the bone bruise part can look, again, something like this in surgery, where it's just, you can tell the bone has been impacted, been suddenly loaded, and then it can have that type of appearance. And it just gives this dull ache in the knee. Unfortunately, bone bruises can take, depending on the size of the bone bruise, 3 to 5 months to heal. I saw a patient today in the office that we had an MRI of a bone bruise, and hers was very extensive. And unfortunately, I think it's going to knock her out for the season. But luckily, no surgery. They heal, but they're frustrating because they take a long time to heal, and they can cause a lot of pain. Tibial plateau fractures. So these are very common in skiers, particularly, less so in snowboarders, but we see them in snowboarders. And it's where someone really what happens is the femur bone, the bone above, comes down and acts as a big hammer, and it hits the tibia and crushes the tibia. Usually there's some rotational stress to the knee, where oftentimes people will tear their MCL, and then the femur comes down and loads the outside of the knee, where the bone is actually softer. The bone's soft on the outside and tends to be more dense on the inside. And then again, the femur acts like a big hammer to crack the bone, and it unfortunately oftentimes can pulverize the cartilage too. And so those are not good injuries. And it's much better, for instance, if someone came in and they just broke the shaft of their tibia, like a boot top fracture, because it doesn't involve the cartilage. These injuries involve cartilage. And so, the goal in surgery is I tell people, it's like there's you once had a nice paved street there, a nice surface that was lined up, and now you have a big pothole in your cartilage. And the best we can do is honestly create what I call a cobblestone street. So I'm sorry, I have all these kind of stupid examples, but that makes sense to some people, I think. So we create these cobblestone streets in surgery, and that's really the best we can do. And so this is one. This patient here, they cracked the cartilage, and they drove the cartilage down, and the cartilage belongs way up here, but you can see how it's pushed down. And so if we just leave it like that, the knee's not going to do well. Plus they broke here and they broke here. So pretty bad injury. And this is kind of what they end up with. So, we have to do plating on the inside and the outside of the bone to hold it all in position. And then in the process, we built that bone back up. So we restored that surface. And I oftentimes will, in surgery with these injuries, use an arthroscopy. So we'll put a camera in the knee, and like this is the before picture, where the big hole in their paved street, and all these are chunks of cartilage and bone that are just driven down like an inch or so. And then this is the after picture, where we've kind of raised all those pieces, and we'll use bone tamps through the bone to kind of elevate these fragments and get them all lined up. But I love using a scope if I can, because I can see so much better. Otherwise, you're using like a live x-ray machine to line things up, which works pretty well. But with a scope, we can kind of confirm that we have everything reasonably well lined up, and then the cartilage it'll heal together, the cartilage, kind of like with a seam of scar cartilage. So Lastly, I think we're coming up on the end here, articular cartilage lesions. So this is a knee that is exposing this big defect in the cartilage. And again, we have this coating cartilage on the end of our bone, kind of like the end of a chicken bone has white cartilage. We have it on the end of our bones. And this patient just knocked off a big chunk of their cartilage. And, I tell people that the holy grail of orthopedics is regrowing cartilage, and we're not there yet. And we're probably not going to get there even in my career. But we have now some newer techniques to regrow cartilage. And so this was a young patient. I think they were only about 20 years old. They knocked off a big chunk of cartilage. And in the old days, we maybe just say, we just clean it up and say that's the best we can do. But now we can actually take a biopsy of their cartilage and send it to a lab in this company, and they'll multiply the cartilage cells, and then we get them back and we sew them under a patch. And then kind of that will actually grow and fill that area with new cartilage cells. And it's not pure cartilage. It's kind of a mixture of scar cartilage and normal cartilage cells, but it's the best thing available as far as technologies available to us. There's some other methods, but this is a good one. I think lastly, patellar dislocations, maltracking. I mean, so you can dislocate a kneecap. This is a woman that I just had in the office, and she's been a maltracker her whole life. So she can do this comfortably, honestly. Well, I shouldn't say comfortably. She has pain, but otherwise we'll see people in the office that they've skied and they've had a dislocation of their patella. And if you dislocate your patella one time, it's usually not surgery, but if you dislocate it again and again and again, then it's usually a procedure whereby we are using oftentimes a donor tendon to reconstruct a ligament to hold the kneecap in place. So those are kind of some common ski injuries, snowboard injuries that we'll see. I know I threw a lot at you. I hope I didn't gross someone out too much. And I think Josh is going to take over now.
Thanks, Dr. Cunningham. Yeah, let's see if this works. If I can share the screen. Perfect. All right, so yeah, I just want to kind of build off of what Dr. Cunningham was saying. We're with Avalanche Physical Therapy. We're in Breckenridge at the Rec Center. Our office in Frisco is actually right next to the VSO office at the hospital. And then in Silverthorne, we're off Adams Avenue. And then just a little bit of bio on me. If you've watched these before, you've already seen this, so I'll go through it quickly. Just a doctorate of physical therapy, orthopedic certified specialist, and then champion performance specialist. Worked the X Games with the UK and then Canada. I actually just got back from the X Games on Sunday, so that went out pretty well. And then, level 2 dry needling certified. And we also do aquatic therapy at the Rec Center. So we do that every Thursday, which can be really good for knees, especially if they're partial weight bearing, but we'll get into that as well. One thing that we do that's really nice is free screenings. I actually just did one yesterday of a knee. And so you don't have to have an appointment. It's probably better if you call so you don't have to wait, so we can kind of, have a better chance to squeeze you in. So you're not waiting in the lobby. But let's say you go up on the mountain today, a lot of powder, and, you felt something weird with your knee or any other body part, honestly. And you don't know if you should go see a doctor or, if you just, what's going on. So you can come in, one of the physical therapists, we're all trained in special tests to, help diagnose injuries. And, we can test it and kind of see what's going on. If we do feel like, if something's bad, like maybe an ACL tear, then we just send you over to Dr. Cunningham and get that fixed up. And sometimes you didn't do it as bad. And sometimes like, oh yeah, it's a little loose, but you should be okay. But it's just a nice, easy and free, which is rare in the medical world, of just kind of seeing what's going on with your knee. And get you kind of to the right person directly. So otherwise you could go to the ER, which is great. They do a great job, but it's just a lot more expensive. You can wait for a few hours as opposed to just coming straight in. We can hopefully direct you to the right person quickly and get you back out on the hill as fast as possible. For recovery, whether it's operative or non-operative, big thing in the beginning is decreasing your pain and swelling, helping improve motion. We want to normalize your gait, so making sure you're walking normally. And then, of course, improve your strength, your functional mobility. And basically the goal, everyone that's working on you also loves to be out on the mountain as well. We were talking earlier of how, this would have been a good day to kind of go late to work so we could enjoy the fresh powder. And so our goal as physical therapists and, as your surgeon as well, is to get you stronger than you were before. So, we want to find any, inconsistencies or muscle imbalances and get you back to better before. So then you don't have to come see us anymore. You can just have fun. Some instruments that we use to assist in your recovery. One thing is blood flow restriction therapy. That's what that guy has on his legs. Basically, it's a way that we can kind of trick the body into building muscle. They send off the growth hormones. Typically with building muscle, you have to add weight, usually less reps. But sometimes, depending on what's going on in the beginning, especially, you can't add a lot of weight. You might not even be full weight bearing. So this is a way we can kind of trick the body into starting to build some mass. It actually started with bodybuilders, probably 30 years ago or more. And then now it's become more common with physical therapy. We'll do functional dry needling, which can help calm down muscles, but also get them to fire appropriately. So sometimes with a knee injury, especially, your quad just kind of turns off. And so it's a hard time to get that quad to fire. So we can use the dry needles, and then we put some electrical stimulation on it as well to get those quads to really start firing if we want to. Therapeutic cupping works as well. Just a big thing of getting in blood flow in the area, help the body heal itself. And then aquatic therapy. We kind of talked about this before. One of my favorite things to do with aquatic therapy is get people in the pool and do things that they're not really technically allowed to do on land. So whether that be walking with good form, even jumping, we can get people in there jumping quicker, because the worst part about jumping is the landing. So sometimes I have you in the deep end, you'll just jump up from the deep end, work on kind of getting that coordination back. With the buoyant force, you can have, if you're up at shoulder height, you're 10% your body weight, nipple height's 25%, hip is 50%, and then knees is 75%. So you can take off a lot of weight, so you're able to do more things without stressing your body as much. And then also at the Breck, or at our clinic at the Breck Rec Center, we have full access to the rec center. So when you come, you're allowed to use the entire rec center with us, and then also you can get a workout in afterwards as well. The rec center's been great in working with us, and that includes like the turf field, so like return to sport type activities when you're getting there in your recovery. We can do a lot of testing and dynamic activities on the turf field, as well as lifting weights in the pool, as we talked about before. The question we get all the time: how long until I can return to activity? Ultimately, each case is different. When I put generally 6 to 12 months, that's kind of from an ACL and returning to skiing. Everything's a little bit different. And it's a case by case. So each patient comes in, everyone likes to compare themselves, like, oh, this person went back to skiing 6 months after the ACL. How come it's taken me 8, 9, 12 months to get back? Well, maybe you had a different type of ACL tear, as Dr. Cunningham talked about before. Maybe you have a meniscus part with it. Maybe you just weren't able to get your motion back. You develop a lot of scar tissue. So, it's nice to hear from your friends and all, of like how they recovered, and kind of take that with a grain of salt on your recovery. But yeah, putting in the hard work and getting back to it is the goal for sure. And then one thing that we need to see, no matter what the timeline is we need to see functional signs and achievements from the patient to return to sports. So we want to make sure you're not doing a one-legged squat and having that knee valgus, making sure you can do jumping in about similar to your other leg, like the person's doing below. And then we do have a return to sports test that's pretty extensive that we take you through as well, to kind of make sure that you're at the best stage to return to sport, hopefully without another injury. And then also we're good at helping prevent injuries. We'll analyze your anatomy, and look at your performance, kind of see how you are. There's different anatomical makeups, even from male to female, that kind of puts you in a position that, you may have a higher chance of, tearing an ACL or a ligament. Also muscle imbalances. Pretty much everyone up here is fairly athletic, but sometimes your particular muscles get very strong, and then your stabilizer muscles, are strong, but they don't equal how strong your other muscles are. And the body likes symmetry. So when the body's not in symmetry, that's when problems can arise. And then when COVID's not happening, we actually run a return to sport class, usually one in the spring and one in the fall. We'll do it in the turf field. Ages from 18 all the way up through 75 is what we've had before. But kind of we do it when the seasons are changing. So when we're getting ready for winter season and skiing, snowboarding, and then when we're transitioning to more of our summer activities, we'll do this class. So maybe this spring, fingers crossed, we can do it. But basically, we're just trying to get your body ready to return to sport. And then hopefully you guys don't have to see us during your season. With that being said, you can be as strong as possible. We can try to do everything we can with preventing injury, and you've done everything perfectly. And sometimes things just happen. You see it all the time with professional athletes. And sadly, let's see if this thing pulls up. We had that with one of our athletes from Canada. So this was Friday, and this is Cassie Sharp.
Last week, training over at Copper Mountain. So will we see a cleaned up version of it on this first hit? New trick for Cassie Sharp.
Just last week, that's incredible. That's insane, bringing it out at X Games. There it is, the 1260. Oh.
And so, with that, it's, now we're going to lose the other thing. With that, she's high level athlete. She won gold in the Olympics. She's been all over the place, and sometimes things just happen. So, it is what it is, and sometimes you can't prevent it, but we're here for you if you need us. And yeah, please call us if you do. But that's all I have for you guys. Apparently I've lost my slides, but that doesn't really matter. But yeah, if you guys have any questions, feel free.
All right, so everybody feel free to submit your questions. We're gonna go ahead and start reading some of these off and answering your questions. All right, so we have one, and she says she would like to know how to prevent common knee injuries when you already have your knees in pain. I suffered a lot of injuries in my knee and quad, from tear ligaments to a tear quad, each north and south hemisphere winter season. None of them needed surgery, but after one day of riding, the pain suddenly appears. Can you recommend any nutrients or something to feed my muscles, bones, and ligaments? I'm a snowboard instructor, so I want and need to be okay. And the doctors say that I'm okay, but my knees aren't.
Yeah, I mean, for that, definitely getting strong. And what does strong mean? You want your quad strong, you want your hamstring strong, of course, your hips want to be strong. Working that transverse plane with your rotary motions, so your glutes. And then in regards to, supplements, a lot of people like taking protein. Turmeric's been shown to help with inflammation if that's going on with you. And then just, your daily vitamins as well to make sure you're set up best for healing.
Dr. Cunningham, anything you want to add to that, or should we move to the next question?
Yeah, no, I think Josh covered in that. It sounds like that particular question, the patient obviously has had a lot of things going on over time, and but nothing that resulted in any kind of surgery or major injury. I think, and Josh probably notes this too, but I would say the one thing that I find in our mountain athletes, that people are skiing, biking, hiking, we get pretty strong in our quads and our hip flexors, but we kind of ignore our glutes and our hamstrings. And then you get tightness in your IT band, and you start to get some patellar maltracking. So if anything, I would say, get on that foam roller, roll out that IT band, work on your hamstring and your glute strengthening, because that's, and Josh can pipe in, but those are the imbalances that I see the most. And then when you get those imbalances, unfortunately, it predisposes to injury, because you get that valgus alignment of your knee. It can predispose you to an ACL tear. And then a lot of people get a lot of anterior knee pain, like kneecap pain, pain under their kneecap going up and down stairs or squatting or lunging, things like that, due to those imbalances. So it sounds like that particular person, nothing interventionally that I'd recommend. It's more preventative and working on any muscle imbalances.
Awesome. All right, next question. I recently viewed an advertisement from a Denver location concerning injection of substance that would replace the cartilage and possibly prevent necessary knee replacement. I currently have bone-on-bone knee issues in my left knee. According to the advertisement, the procedure is approved both by Medicare and the FDA. Are you aware of this procedure, and is the result longer lasting than cortisone or other injection type procedures? Is this an option for a bone-on-bone arthritic knee?
Yeah, and it's honestly, it's unfortunate in a way that there's a lot of direct-to-consumer marketing when it comes to injections like this, and it's probably they're talking about like a platelet plasma injection, a PRP injection, or a stem cell injection, and we do those in the office as well. But I think you know, the FDA does not regulate those types of injections. So biologic injections, whether it be platelet-rich plasma or stem cells, they're not regulated by the FDA as long as we follow certain guidelines, mainly that we just can't manipulate the cells. We can't concentrate the, for instance, we can't concentrate stem cells in this country. We can't grow stem cells in culture. And so as long as though, let's say a common source of stem cells is typically taking them from one's pelvis bone. But for every million cells we get out of one's bone marrow, about 100 or so are stem cells. So there are some stem cells in there, but it's actually a very, very small percentage. But that's probably what they're referring to. There's really no other technology out there that you know, is available to us. And believe me, as an orthopedist that sees a lot of knee injuries and cartilage loss and bone-on-bone arthritis, I feel like I'm up on the latest and the greatest. But you know, it's a little unfortunate though that you have these clinics popping up that are making claims like, hey, we can save you a total knee, you're bone on bone. If I inject this mixture of stem cells and PRP in you, it's going to grow you new cartilage. Because really those claims are not backed up by science. And so when we look, you know, in orthopedics, we'll take 100 people where we inject them with that sort of mixture versus 100 patients that don't. We'll randomize patients, we'll see how they do, we'll do follow-up MRIs, let's say, or even follow-up surgeries, and we just don't see those results. But you know, a guy on the street that throws up a clinic and unfortunately charges people a ton of money typically to do these sorts of things, doesn't have to back those claims up with any kind of science because they're not regulated by the FDA. The FDA doesn't get involved. So I'd be careful. I think, no, is it going to hurt you? Probably not. But is it going to cost you a couple $1,000s and possibly really not have much of a benefit for you? That's possible. There's you know, if you know, sadly too, if you're spending a couple $1,000s on a stem cell injection for bone-on-bone arthritis, there's a placebo effect there, and you're typically going to say, "Wow, I feel better. I feel great." Well, that placebo effect is strong, especially when there's, you know, when you're invested in it. So, but I don't think it's going to hurt you. But no, there's nothing that I think any clinic in this country at least is doing that's any different than our office or other good orthopedic offices out there. There's nothing new that they're offering.
Cool. So it looks like we did have somebody ask how to submit questions, and I haven't seen a question submitted from that individual yet. So I just want to let that individual, as well as everybody else, know that you can type your questions right into the chat box and we'll see them, or you can hover to the bottom of the main screen and you can click the Q&A button and submit your question there. Okay, so on to the next one. How hard should I push on the exercises during recovery? Should they push to the pain, or they want to know if they should push past the pain?
That's a really good question. I like to say, you know, being able to analyze what your pain is telling you. So, you know, if you're getting a sharp pinching pain, that's your body telling you to stop. So if you're getting that, don't push into that. A dull pain around a 3 or a 4 or so, you know, that's okay. You can push that a little bit, but if that pain starts to escalate, then you kind of want to back off, because you're right. There is that fine line of doing too much and then kind of setting yourself up for failure. But those are my best advice. It's just, if it's a dull pain, you can push it until that dull pain starts to escalate. And then if you have like sharp pinching pain, that's when you either want to stop that activity or change it so you're not getting that sharp pinching pain.
Next question. Is there a specific name for the ACL repair technique you mentioned versus full reconstruction?
Yeah, and it's really called primary ACL repair. That's the name of the procedure. And then, as you mentioned, there's ACL reconstruction surgery. And again, most patients are not going to be a candidate for repair surgery. I would estimate in my practice, which is just sports knee and shoulder injuries, it's probably about, for every 50 reconstructions I do of the ACL, there's maybe 1 repair. So it's not that common, but I think, as a knee surgeon, I want to be on the lookout for it, because if someone is a candidate, if for my knee or my daughter's knee, I think it's a great option in the right type of tear. But that's really what it's called, is primary ACL repair. And if you saw, let's say, a surgeon, an orthopedic surgeon that's maybe doesn't see a lot of ACLs, I think, and you said, you mentioned ACL repair, they might say, oh, that's crazy. You know, ACL repairs don't work. Well, we did ACL repairs as orthopedists back in the 1970s and the early 1980s, and they did not work at all. They were terrible. But the ACL repairs of the 70s and the 80s are vastly different from what we do today. I mean, back then, first of all, surgeons were doing a big 6-inch incision and opening the whole joint. Arthroscopy didn't exist at the time. Surgeons were repairing all types of tears. So the tears right in the middle of the ligament as well as those up high. And we were putting people in casts for 8 or 10 weeks and not accelerated rehab like we do today. We didn't have bone anchors back then. We didn't have high strength sutures. So there are so many things that were just, it's really apples and oranges to the repairs that we're doing today. But anyways, that's a long answer to your question.
So we got a few more questions coming in. Next question, is there anything other than simply rest that you recommend for healing a bone bruise?
I would say, yeah, rest, and I oftentimes do send patients to physical therapy because I do think that helps. And you know, our goal is to, hopefully you're going to get typically some atrophy because of the pain in the knee and your disuse. You'll get some disuse atrophy, but you know, having you work with someone like Josh, he could do some of that blood flow restriction therapy, get you on a bike, maybe spinning on the bike, doing some things to maintain muscle mass and range of motion during that time. But you're right, the mainstay is avoiding any type of impact activity that's going to further bruise that bone.
And that might be a good thing for the pool as well, where it just takes weight off of you and you can do a lot of things that you wouldn't be able to do on land, but also listening to your body and, you know, getting that sharp pinching pain or that pain where the bone bruise is, that's a negative. You don't want to go that route.
This is kind of going off, you know, healing certain issues, but we had another person ask, what are the best things for, you know, rehabbing a tibia plateau fracture? So they want to know what the best kind of exercises in rehab would be.
Yeah, and you know, typically with those fractures, unfortunately, we have to keep people toe touch weight bearing, or you can rest your foot on the floor, but we can't have you weight the leg, because you know, we're propping up all those bone fragments, and then we put bone graft underneath it to fill the void where the bone was kind of crushed. And so you have, you know, the cartilage layer built back up and lined up as best as possible, and then bone graft underneath it, and then, you know, screws that are kind of through a plate holding it all together. But we can't have you put any weight on it, because then we worry that you're going to press that surface back down if you weight bear on it. And unfortunately, with tibial plateau fractures, we have to keep, depending on the severity of the fracture, we have to keep people off it for a minimum of 8 weeks, sometimes 10 weeks with no weight. And but during that time, we're starting range of motion. You know, based on x-rays and how things are looking, starting some weight bearing at 8 to 10 weeks, and then progressing the strengthening. And Josh, feel free to pipe in on any rehab of those.
Yeah, I mean, definitely case by case, but I mean, that's kind of thing. You take things nice and slow, let the bone heal. I call it the boring phase of your recovery, but it's a very important phase because you need the bones to heal. So we try to do as much as we can, keep your range of motion. Make sure you're not losing but so much muscle and keep you functional. But you know, if we try to push things quickly and that bone doesn't heal properly, then you're going to be in a world of trouble down the road. So it's better to be a little patient in the beginning and not have problems down the road than try to move too fast.
So we are getting a ton of questions, which is great. Want to thank everybody for the great questions. We're going to keep going here. Just want to let everyone know, bear with us a little bit as we get through these. So let's go to the next one. We have a question. What are differences in clinical findings between a normal ACL tear and an ACL avulsion tear? Would a Lockman test be positive for pain and laxity in both cases?
Yeah, that's a good question. Excuse me, the exams in the history and the physical exam is very similar. In some cases, if someone does have an avulsion and let's say they haven't peeled all the ligament off the bone, let's say there's still some attached, then the knee might not be as unstable when I examine it. But oftentimes it's completely detached and the exam is exactly the same as a mid-substance tear. And then it really takes that MRI to look at and say, oh, wow, this is a very proximal or high tear of the ACL, and it might be amenable to a repair. But in most cases, the presentation, the history, the physical exam, everything is very similar, if not the same, to a mid-substance tear.
Yeah, and that's where, like, if we were doing a free screen and, we're not feeling that infill on the Lockman like we thought we would, then we're like, all right, that's, we've done our part. Now it's time to go to the specialist, and we send you to Dr. Cunningham so you can kind of figure out what your best course of action is.
And I want to jump to another question just because it's a patient asking, or it's a person rather asking if they should come in and see you, Dr. Cunningham. So just in case they hop off, I want to get to them. So they asked, my right lateral collateral ligament talks to me, quote unquote, sometimes when I ski. Is there any strengthening exercises or information I should know about, or should I see a PT or Dr. Cunningham?
Yeah, and lateral-sided knee pain in skiers in particular is very common because with that being your downhill ski and you're loading that downhill ski, you tend to stress the lateral compartment. And it's a very common perception that the pain is coming from the lateral collateral ligament when usually it isn't, honestly. Because a lateral collateral ligament, if it is a lateral collateral ligament injury, that's an acute injury where you have usually a massive blow up out there, like an ACL type injury. And you feel pops, pain, instability in the knee, your knee swells, it fills with blood, your knee feels very unstable when you're walking. And then an injury like that to let's say a lateral collateral ligament, they tend not to heal that well, but they do tend to scar in somewhat over the first 8 weeks or so. But if you haven't had an acute injury, it's probably not your lateral collateral ligament. It's probably, honestly, the most common thing, honestly, is you're starting to get some arthritis on the outside of your knee. And when you're loading that ski, your downhill edge, you feel it on the lateral tibial plateau just because that articular cartilage, that cartilage is starting to get thin out there. Or a lateral meniscus tear, where you have a tear of your lateral meniscus and it's causing pain when you load that outside edge. But it's honestly not probably your lateral collateral ligament. So it might be a good idea to come on in. We do x-rays, first of all. We look at, get a history, do a physical exam, get x-rays. If we saw that your lateral compartment was really collapsed on an x-ray, then we have our answer. Then it's arthritis. But if, let's say, your lateral compartment is well preserved on an x-ray, the spacing, then in let's say you had pain over your meniscus, you might have a meniscus tear with an unstable flap that's catching in the knee. And then it probably would be an MRI scan to evaluate for that.
All right, next question. What do you think of recent research about running perhaps being beneficial to the knee function long-term? I've always assumed the opposite.
Kind of depends on how you run. So there's a lot of, different things. And it also depend on like who you are as a person. You've been running for a long time. Do you have good form? Are you overweight? There's a lot of different variables. But most of us are heel strikers. Most shoes are made for us to heel. They usually have a higher heel lift. Now there's more minimalist shoes, which can be like, there's not much padding, or it just means that there's not a big difference between your heel to your toe. So usually that's dropped down to like 4 or 5 millimeters. Typically it's around 8 millimeters, and that kind of puts you up so that when you heel strike, you're not putting that impact all the way through, your body basically. So, with heel strikers, there's a lot of impact force, and that goes through the bones. So maybe that's going into your ankle, maybe it's going into your knee or your hip, something absorbing that weight. And then people have changed their gait, or they run naturally at a midfoot or forefoot, where now your muscles are taking it. So you got to be a lot stronger. You need to have your calf be nice and flexible. But when you're hitting on your forefoot or your midfoot, what you're doing, this is a foot now, you're hitting on this area, you're coming down and you're doing that pronation, not the overpronation, but you're pronating like you're supposed to, absorbing weight. The calf is taking some of that stress, and then also, your upper leg is also taking some of that stress. So your muscles are taking that force. And so then it's less stressful on the bones, but that can lead to other problems. So it kind of just depends on, what type of runner you are, what you're showing, what type of pain you're presenting with. But it definitely can be, not bad for your legs for sure. But it's a case by case situation. And, that's something we can do at the rec center as well, as we can get you on a treadmill, look at you, videotape how you're running, and do a gait analysis and kind of see if there's anything going on there.
Yeah, I would echo what Josh said. And I think, people can run late into life as long as they have normal mechanics, like someone, let's say, isn't excessively bow-legged or excessively knock-kneed, or let's say someone had a prior major injury to the knee and they lost a lot of meniscus that couldn't be repaired. Those are circumstances where probably if you ran at least a lot of miles, you're going to probably accelerate the wear in your knee versus, let's say, riding your bike. But I think someone with normal mechanics who hasn't had major knee injuries can run late into life, and it's not going to accelerate wear in your knee.
All right. What stretching and strengthening exercises can a person do with a previous meniscus tear and arthritis? How can I increase range of motion?
Without looking at you, I can just give, general ideas. Definitely range of motion, simple as just heel slides. You can use a strap to kind of help pull your leg. You can lay on your back with your leg on the wall and let kind of gravity help assist getting your range of motion back. What are you allowed to do? It depends on how you're feeling. So typically with meniscus, when you're getting into more of a weighted deep squat or lunge or something like that, sometimes, you can have that extra pressure on the meniscus and that'll hurt. So that'd be a time where, maybe you don't go as deep if it's hurting. But kind of like we were talking about before, getting everything strengthened. So the stabilizers, your rotators, your glutes, your hamstrings, and just making sure that everything's symmetrical and even so that when you're going doing your sport, you can handle all the different things you're doing.
Okay, we got a couple more questions about meniscus tears I'm going to read off. So if you also have a meniscus tear, is it possible to tear that again or have long-term issues? How do you address post-injury and after ACL replacements with a meniscus tear?
Yeah, so again, most patients with meniscus tears, it's kind of that wear and tear event. And typically the age range, the most common age range is that kind of 40 to 6-year-old patient. And my analogy with meniscus tears is it's kind of like a fan belt in your car. You only get so many miles, and the harder you drive that car, the more likely you are to weaken the meniscus, and then one day it just tears. Usually there's not a major trauma when one tears their meniscus, although there can be. But the 90% of the time, someone's just said, "Oh, I was squatting down in my kitchen," or I was a carpenter and I'm squatting down, or I twisted and I felt the sudden pop and pain. But if it didn't happen that day, it would have happened 2 days later when you were coming down the stairs. It's like it was about to tear. And I think as far as the meniscus goes, I think one of your questions you had was, let's say you had one tear, and let's say you came to surgery and we had to remove that torn flap. Can you re-tear the meniscus? Yes, you can, although most people tear one portion of the meniscus, like on the medial side, they tend to tear the back of the meniscus. And if we had to remove that torn flap area, then the most common area to tear has been removed. So it's unlikely to get another meniscus tear. You can, but more likely it's just that as time marches on, you start to get more arthritis in that part of the knee. And then arthritis becomes a bigger player as far as what's causing the pain in your knee. And I think you asked about meniscuses in the setting of an ACL. Yeah, and that's where I think ACL surgery, if someone's had a really anatomic reconstruction, like we put that graft perfectly in the knee, and it's a nice tight reconstruction, you've had good incorporation, and your knee's nice and stable, then you're no more likely to tear that meniscus than the meniscus in your other knee. It is the case, and I don't mean to, point fingers or anything, but we do so many ACLs here, and there's some studies that have shown that the majority of ACLs done across the country are done by surgeons that do 20 or less a year. And I know if I did 20 of something, I'm not as good as if I do 100 of something. And so there's some reality there that if the ACL is maybe not done as well in the knees, let's say, has some persistent laxity to it, then you're stressing your meniscus more so, and then it's more likely to tear. So those are some of the factors, I think.
Okay, I got another meniscus question. This one's for Josh. Is it true that meniscus tears can sometimes be treated successfully with physical therapy only? And they said, I realize the meniscus tear isn't fixed, but as I understand it, the results for the patient are similar.
Yeah, definitely we've had success with that. Depends on a few factors. So sometimes, if you're getting a lot of like kind of popping, clicking in that, joint line area, and especially if that knee's locking where it kind of gets tight and then you kind of have to move it around just to get it to unlock, those probably aren't going to do as well. And we would send you over to Dr. Cunningham. But yeah, some of the smaller meniscus tears, and depending on where they are located, can definitely do well with just conservative treatment. One thing I like to live by is, we have you in for 2 weeks. They were seeing you 2 or 3 times a week for 2 weeks. We should see improvement in 2 weeks. Are you healed? Probably not, but we should see improvement. If we're not seeing improvement, then something else is going on. So sometimes we think that we can heal something conservatively, and then 2 weeks are going by and you're just as bad as before, just not really doing better, then we just send you to, someone like Dr. Cunningham as well. So, you can get to the next step, because it do you a disservice if we're just, if we're just treating the same thing and we're kind of banging our head against the wall, so to speak, for like 6 weeks, and then nothing really gets better. Then we finally send you over to somebody else, and just kind of delays the process. But yeah, to answer your question, definitely some of those smaller tears can be treated conservatively successfully.
Okay. We have another question. How do I deal with chronic swelling 3 years after a non-displaced, minimally depressed TPF that affects my flex and strength?
I think as I understood the question, it's 3 years out from a tibial plateau fracture with persistent swelling. Yeah, and that points to probably the fracture being fairly severe, where you really unfortunately injure that articular cartilage, that coating cartilage layer. And, again, the surgeon, I'm sure, did their best job of trying to restore that alignment of the cartilage. But sometimes if the cartilage has really been fragmented into a lot of little fragments, that surface is not normal, and it's the cartilage has been damaged, it's thin, and it's basically honestly like you got arthritis in one day because you hurt the cartilage. Most people wear the cartilage like wearing treads on a tire. With a tibial plateau fracture, I said, in some cases, unfortunately, you just really damage that cartilage so much with a fracture that although it was put back together, the cartilage is going to wear thin and not be totally lined up and continue to cause pain and swelling in the knee. So then we direct symptoms toward your arthritis in effect, and that's where things like let's say a Synvisc injection, a hyaluronic acid injection, maybe we'll consider a PRP injection to help calm down the inflammation caused by the arthritis, and then physical therapy, possibly an unloader knee brace. We might think about if your knee is malaligned a bit and overloading that area. So those are things we might consider to try to control your persistent swelling and pain if you have it.
Okay, so going off that, we have another question about tibial plateau fractures. Not sure if this is from the same person, but I'm gonna give this one to Josh. So after a tibial plateau fracture and now in a fixator to straighten it, what is the best exercise to focus on, and how long should I wait before having a knee replacement?
So for that, I'd wonder if you're in an external fixator, or if you're on like a brace that's going to work for more of your extension if you're having a hard time with extension. Obviously, it's trying to get that extension back. So one of the main things, getting the range of motion and knee flexion as well coming back. I'm not sure how recent you are after surgery, but definitely getting your range of motion back. And then if you're weight bearing and you're able to do certain things, just trying to get that quad control back, getting your gait normalized. In regards to how soon to get a knee replacement, I kind of have to put eyes on you to give you an accurate answer. But if you're already seeing an orthopedist for that, you could definitely talk to your orthopedist and kind of see where everything's standing and if that's an option for you.
Okay. All right, we got another one. I'm a 57-year-old male that has skied for 50 years and probably over time was degrading my knee. I had a 30% medial meniscus tear 2 years ago, and just like Dr. Cunningham said, they cut away the flap. But ever since then, I constantly have pain in my knee and it's never recovered 100%. Do you have any suggestions of what I should do? I've been to PT and a chiropractor where they did the cupping, scraping, dry needling, etc. Is there any hope for me to get my knee back 100%?
Yeah, and like a lot of people, especially someone that is skied hard for 40 years, I think, like 50 years, like you said, usually in addition to the meniscus tear, I wouldn't be surprised if they found some thinning of your cartilage, your coating cartilage. And obviously that flap and meniscus, that probably made you feel better getting that out of there, but it's not surprising you were left with some pain. And I tell patients kind of the pain that remains, it's really not like a new tear of your meniscus. It's just the fact that coating cartilage has some wear there. And as you and I get older, that coating cartilage is going to start to, thin more so. But the non-surgical things that we can do, I think, are, that hyaluronic acid injection is a nice one because insurance covers it. So we oftentimes will do that. The PRP can help as well. Neither of those are going to grow us new cartilage, but they help calm down the inflammation. And I have a lot of my ski patrollers and ski instructors every fall. They see me for their their hyaluronic acid injection, and then I don't see them for a year. So that's one thing we can do. If your wear is mainly in the medial compartment, an unloader brace can work quite well to unweight that compartment. You know, will your knee be normal? You know, unfortunately, it's probably not going to be the knee that you or I had when we were 20 years old. But you know, believe me, everyone in Eagle County, Summit County has some wear and tear, and there's certainly things we can do to make you better, make you functional, and hopefully, you know, relieve a lot of that pain. And Josh, I don't know if you have some things to add there too.
Yeah, no, I love that answer, because it sounds like you've done a lot of the conservative stuff. So, you know, if that's not working, then, you know, I would say kind of go with what Dr. Cunningham was saying. And then, you know, potentially after that, then maybe going back to like PT to kind of help you, you know, utilize all the stuff that you were given there to help get you back on the slopes, you know, as long as possible before avoiding the total knee replacement.
Okay. All right. How much does age play into the procedure recommendation for a slight meniscus tear with osteoarthritis? i.e., is a knee replacement the only option for a 69-year-old who's already had 2 rounds of rooster juice, not sure what that means, and cortisone shots with not much improvement?
Yeah, and rooster juice, that's the term that we hear all the time for that hyaluronic acid injection. So no, I think really we, you know, in my office, for instance, I don't really so much focus on your chronologic age as your physiologic age. And so if I were to look at your knee on an MRI, and let's say you had a big flap of meniscus, but your coating cartilage of the knee was still well preserved at 69, which I sometimes see, then, you know, we're going to just consider a scope, and probably it's that trimming. I doubt it's a repairable type tear, because again, most adults tear in the inner rim where there's no blood supply. But then you could do very well with that. But is really, you know, a scope, I tell people, it's really how well you're going to do is inversely related to how severe your arthritis is. So if someone has severe arthritis, inevitably they're going to have some meniscus tearing, and scopes in that setting do not work well, and I don't recommend them. But if someone doesn't have much arthritis and they have a meniscus tear, scopes work great. And so it really comes down to that, and less so your chronologic age.
Thought this was kind of an interesting question, and looking forward to hearing your answers. Anything you each do to prevent all these injuries that you are so experienced with? Probably hard to give a simple one-size-fits-all answer to this, but thought that was a good question.
For me personally,
And I'm sorry, I lost you, Rachel. Sorry.
Oh, go ahead, Rachel.
I said we just had one question come in that said anything that each of you do to prevent all these injuries that you were so experienced with.
Yep. For me personally, I used to sublux my right patella multiple times, and I would play basketball, rec league basketball and stuff like that. And it had gone twice out in probably 3 months or so. And I thought I was pretty much kind of done with basketball and all that good stuff. And it's been a kind of on and off problem for me for years. But, you know, the main thing that I did, besides like trying to stay strong, was I actually added more plyometrics into my routine. So I started doing like box jumps, one-legged jumps, ladder drills, and kind of get that proprioception back, so you can kind of control that patella in space when you're doing more athletic activities. And, you know, knock on wood, that was probably about 3 or 4 years ago, and it hadn't subluxed since then. So, you know, we're always trying to stay strong, always trying to, you know, hit those stabilizers that we've talked about, make sure we're well balanced to try to prevent things. And then, yeah, sometimes things pop up, but hopefully it's something small that, you know, goes away pretty quick, and we can just have one of our coworkers fix it pretty quick and kind of get back out. So that kind of helps with the job as well.
Dr. Cunningham, do you want to give any response to that?
For me personally, you know, I ski in the winter. I like to skin a lot uphill, and do some alpine, do some Nordic, and then in the summer, in the warmer months, I'm a big cyclist, and so all those activities are really tend to work my quads and my hip flexors, as I was mentioning earlier. And so for me, you know, my personal trainer, who I have used on occasion, is great. Really educated me, you know, 10 plus years ago on how much I really had that tightness in my T-band and my weakness in my glutes and my hamstrings. And so, you know, I've really tried, because my sports are linear when I'm in the gym, working side to side. And so, I try in the gym to, put that band around my feet and do that sideways walks, and on my ball, usually a weight bar to lift my leg out to the side to engage my glutes, and then hamstring work like hamstring curls, deadlifts. So I try, whereas before I might have just gone in and done more quad stuff, which I don't think I need. So for me, that's helped. Certainly I have my, as the British say, my niggles here and there where, I have some soreness in my hips and my knees, and it's just, I think, unfortunately, all of us being as active as we are and getting a little older, I think it's something we have to deal with and work through.
Awesome. All right. I slipped on some mud on our road. My right leg extended out very far. I have pain on the inside of my knee occasionally that comes and goes. The other day it was so painful I couldn't put weight on my leg. Once I limp around for a while, I can get back into a normal walk. 67-year-old female, very active. I think this person's just, wasn't really a question here, but just looking, for some advice, or maybe if she should come in for a follow-up or to get checked out.
Yeah, maybe I'll just jump in. I mean, it sounds you're kind of describing possibly a bone bruise or a meniscus tear. Those would be the two things that would pop to my mind with that history. And they really take two different courses. Like bone bruises, if you rest them, they're going to slowly get better. Like week by week, you're like, oh, I'm feeling better, I'm feeling better. Whereas meniscus tears, they can get a little better and then they plateau and they continue to cause pain. And so, if it's been, you could give it 6 weeks or so, depending on your patience, I suppose, and desire to get back to things. But if you haven't seen that kind of week by week improvement, then probably a good idea to come on in and get evaluated.
Let's see, I had knee surgery for a damaged meniscus recently, and about 6 weeks after the surgery, I developed systemic arthritis, polymyalgia, rheumatia. Sorry if I pronounced that wrong. Is this a common problem secondary to this type of surgery?
It's not, that's unfortunate. Because polymyalgia rheumatica, it's basically like the systemic inflammation that can affect many of our joints. So in just having done this for 20 years and a lot of knee scopes for meniscuses, thousands, I don't know that I can think of one patient that's had that develop afterwards. So I don't know that it's related to your surgery. I mean, sometimes the stress of an event like a surgery possibly could bring something like that on, but I'm even grasping to link those two things together. So, I think I'm a big fan with systemic rheumatologic or systemic inflammatory conditions of eating an anti-inflammatory diet. So eating a lot of plant foods, whole plant foods, and staying away from processed foods, and maybe that big green smoothie every day or that big salad at lunch. So definitely load up on the plant foods as natural anti-inflammatories. The turmeric that Josh mentioned, I think that's a great, non-pharmaceutical anti-inflammatory. It's been shown to be effective, but otherwise you probably need to see a rheumatologist too, and see what they have to say as well.
Do knee sleeves and support wraps help skiers support their knees? How much are they helpful? Will knee support help prevent knee injuries in a healthy, strong athlete?
They can provide help. I think they do more like a tactile cueing, so you can kind of feel your knee in space a little better. But for instance, for me, when I would play basketball, my knee would mess up on me. I actually bought those like 3/4 tights. And, I don't know if it's placebo or what, but I feel a lot more comfortable with them. I feel like I have more control of my body, so to speak. So I do like them. They're not going to help you structurally. They're not going to, like say you had an MCL tear or, you're skiing without an ACL or something like that. It's not going to give you that as much stability to kind of help with that. But that tactile cueing can be very important of just where your body is in space. And so you can use your muscles to control things a little better.
I'm a 70-year-old male who's been pretty athletic for the past 50 years. Unfortunately, I've had injuries in 6 successive years of a partially torn right Achilles tendon last year. Now this year, a partially torn ACL, root meniscus tear, and a slight tibial plateau fracture on my left knee this year. I'm an avid cyclist, uphill skier, Nordic skier, alpine skier, but I fear this muscle imbalance issue. Please advise for future exercises to help.
We've kind of talked over like stabilization stuff. The best way is obviously to kind of get our eyes on you and kind of see, what's going on, where are the muscle imbalance. It sounds like you've had a lot of things going on. So I would bet that there's probably multiple things that we could work on. And, you know, sometimes PT, you know, takes a long time where you're like, all right, you're an ACL, you're going to be here for months. But sometimes it's more of just coming in and, you know, us examining you and kind of seeing where you're at and just giving you some things that you can do that are specific for you. And, you know, maybe you're in for like a visit or two. You come to one visit, we show you some stuff, come back in like a couple of weeks, we show you some more, you know, advanced things, and that kind of gets you where you need to be with all your imbalances and all that good stuff to kind of help prevent injury.
Do you have to have knee injections prior to a total knee replacement? If bone on bone, can you go straight to the knee replacement and forego the injections? I think that's what they're asking.
Yes, is the simple answer. Yeah, and everyone's so different. I mean, you know, some patients, I don't do knee replacements any longer. I did them for a number of years, but my partner does them all now. And but some patients, and it's usually my recommendation that let's try at least one injection of various sorts, just because we want to, you know, we want to, in my mind, kick that can down the road as far as possible. But some patients, I think, wait too long, you know, where they're really disabled by their arthritis and they've given up all the things that give them pleasure in life, and they're having pain at night, and they're just so deconditioned that maybe they should have had it done sooner. But I think it's always a good idea to try some conservative measures before you go right to surgery. But I have some patients that come in the office and they're like, nope, I don't want to try the injections or the PT or the bracing or those other things. I just want to get it fixed. And that's okay, particularly if you're of the age where it's, you know, indicated, and your radiographs, your x-rays are all consistent with you having end stage arthritis that would respond well to replacement.
How does chondrocalcinosis, and I apologize if I pronounce that wrong, play into a knee recovery? Is knee replacement ultimately what you're going to end up with?
Yeah, so chondrocalcinosis is basically some people get mineralization in their cartilage in their knee, and it's usually of their meniscus, but also sometimes their articular cartilage. And we think it has to do with something metabolic, such that people sometimes basically they mineralize tissues in their knee. And unfortunately, it does make the meniscus more brittle when it's mineralized, and therefore more likely to tear. But I see plenty of patients with just chondrocalcinosis and a resultant meniscus tear, but they have no significant arthritis in the knee. And then we would treat them just like any meniscus tear. Usually, again, it's that interim tear that requires a little trimming. But no, you know, chondrocalcinosis doesn't doom you to aggressive arthritis in the knee or an early knee replacement. Oftentimes it can predispose though to meniscus tears, and then when you lose some meniscus, depending on the amount, arthritis can develop at a little faster rate.
So this question came in. I'm not sure exactly what they're referring to. I'm assuming this came immediately after another question we answered. So if we need to move on, that's fine. But they asked, do you identify candidates for that primary repair during arthroscope or just from an MRI?
Yeah, that's a good question. I mean, normally in the office, I'll mention it to a patient, certainly to say, hey, you know, you may be a candidate for this procedure, but it's usually a game time decision. It's usually when we have the scope in the knee and we're probing the ACL to see if in fact someone's a candidate. But I always want to get someone's consent, you know, and make sure that they're okay with that sort of procedure going into surgery, if in fact I feel like it's repairable.
And then we have another question. Individual wants to know about hyaluronic acid shots into the knee to help with the cartilage.
We do them all the time. You know, the results are, I think, overall quite good. The studies are a little mixed, but I found that they work quite well to control the inflammation and the pain associated with arthritis. So, you know, I've done thousands and thousands. They do work, I think, overall for most patients. People that are end stage arthritis, completely bone on bone, at that point they tend not to work. But if you still have some remaining cartilage, I think you're a good candidate.
Let's see. Another person wants to know, what's the best way to deal with chronic swelling of the lateral compartment where my TPF fracture occurred 3 years after a non-displaced, minimally depressed TPF, constantly swollen for 3 years after the injury, and affects flex and strength of my It affects the flex and strength of my knee, so I can't ski with comfort and confidence for fear I can't absorb bumps in terrain.
Oh, and I think, Rachel, we kind of addressed that one with someone,
Okay.
and we would basically, again, we'd go down that arthritis route of treatment, because that's really what, unfortunately, you develop with that tibial plateau fractures, the arthritis. So then we treat it with the non-surgical things that we've mentioned to treat arthritis in your knee.
Gotcha. My apologies on that. So it looks like we have, I guess, one more question. This one's kind of lengthy, but there are a couple specific questions in here, so I'm going to read it to you if that's okay.
Sure.
I'm a 75-year-old female skier. I had an ACL replacement with a foreign ligament approximately 20 years ago. During the arthroscopic ligament replacement, my same knee MCL was detached from the thigh bone and was reattached with open surgery using a titanium anchor. When I woke up from surgery, my surgeon announced the good news, successful ACL replacement, and bad news, open MCL surgery. That put me out on 6 weeks of crutches and 6 months rehab. Before and since surgery, I was and am still wearing a metal fixed knee brace to protect my knee ligaments. Because of my age and declining bone density, still within passing grade, is it possible for the anchor bullet to be dislodged then when twisting the same knee skiing? So that's the first question. There's a couple more after that, but I'll let you answer that one first.
No, the hardware, people worry about that all the time, like hardware pulling out a bone and stuff like that. And no, the more, the more likely thing is that you could still re-tear, unfortunately, the MCL or the ACL with a significant enough injury. But the hardware, to have hardware move or shift in bone is very, very rare. Not zero chance, but it's, I see people, not infrequently in the office saying, "Oh, I feel like my screw's backing out or something," and we'll get an X-ray and it looks the same. So it's very unlikely that your hardware will ever move.
And then she asks, she follows up and says, I did fall and twist that knee wearing the brace a year and a half ago. And I felt that my MCL was affected. It took me 5+ weeks to rehabilitate that knee. Can there be a second MCL and or MRI corrective surgery now?
Yeah, I mean, you definitely can re-tear your ACL. It sounds like it was repaired, of course, 20 years ago. You can definitely re-tear it. And if someone is unstable enough, yes, then we might need to consider another MCL reconstruction surgery. But it would depend on your exam. If we, examined your knee and you just had a little bit of slight laxity in your MCL, we would brace it and let it heal. If it was, 3 months later and your MCL is very, very lax and you didn't have other issues with the knee, like not much arthritis, your ACL is okay, then it might be another MCL reconstruction to give you a nice tight MCL again.
I have another person who's just kind of asking if it would be Dr. Cunningham, if it would be you or if it would be Josh who provides hyaluronic acid shots. And they're just kind of curious for their own coverage, but good question nonetheless.
Yeah, we would do it in the office, and we have to call the insurance company and get it approved. It takes about a week or so to get insurance companies to approve it. But yeah, we would do it in the office just as a simple regular office visit. But we oftentimes first have to work you up and justify the insurance company why you'd benefit from it. So usually we can't do it the same day as we see you. We have to kind of make the case now to insurance companies as to why I think you'd be a good candidate. So it's usually see in the office, evaluate you, X-rays, have a nice clinical note, submit that to the insurance company, say, this is what we want to do, please approve it. So.
Okay, well, I think that pretty much covers all of our questions. I apologize. It looks like we have one more come in. I think we kind of answered most of these. So yeah, if anybody else has any more questions, feel free to respond to the email address that you got the invite for this webinar from, and we will add them into the list of questions that we have. Do you guys have anything else to add or any final thoughts on any of these questions that have come in?
No, I think, thanks everybody. And thanks Josh and Rachel. And
thanks everyone for your time. Our next webinar will be on regenerative medicine for chronic pain with Dr. Matthew Nurkey on February 25th. So if you are signed up for our email newsletter, please keep an eye out for that. If you're not signed up, please head to vsortho.com and go ahead and sign up. Please feel free to reach out for an appointment or any other questions you have. You can reach us at Vail-Summit Orthopaedics at gmail.com, or just head to our website, vsortho.com, where you can request an appointment. All right. Thanks so much, everybody.
Thanks,
Thank you.
everybody.